Good morning. My name is Jonathan Fite, co-founder and chief executive of Beyond Lucid Technologies, an EPCR and pre-hospital HIE company. And essentially what I'm going to talk to you about today, what this long, wordy title essentially says, is I'm going to talk to you about words and numbers, essentially the ways by which we describe the programs that we are undertaking and try to make sense of their value. I'm going to start by giving credit where it's due. So some of you may know Jonathan Washkow, certainly been a force in the discussion of community paramedicine based out of New York City. And this Venn diagram essentially is his description of what makes for a successful program. Safety of the patient and the provider, the satisfaction of both, ideally, and the financial stability of the program. Now, I'm not a clinician. I'm a technologist and an MBA, so I can speak with only limited authority on 2 out of the 3, but I can talk about finance and economics, and so that's what I'm going to focus on today. And speaking of finance, I have noticed, and I'm sure some of you have as well, that we've made some progress in this discussion over the last couple years. My first IRCP conference was back in Reno, so it has been a number of years. And although we have made some progress in discussing how to pay for, support, justify community paramedicine programs globally, we are nevertheless asking some of the same questions. And so in comes this little guy, and his job is to be the biggest geek in the room. Now, admittedly, he's a little bit biased towards data because it's what he deals with all day long. But really, his goal is to try to ask the community that's participating in these programs to ask some hard questions. Break stuff, if you will, shout a little bit. Be subtle like a sledgehammer, as we say, and really challenge every assumption. What is it that's keeping programs from advancing, from scaling? Why is it that so many folks are talking about the complications, the complexity of their own programs? What if we asked, what if we started asking more universally as a community, things like, do community paramedicine programs really save money? Financially speaking, do they stand on their own 2 feet? And if so, or if not, what do we do in order to strengthen that orientation? Before digging into all the details on that, I'd like to talk to you a little bit about the source of the passion. I often get asked how I got into this completely straightforward and never confusing business. And so really I'm going to highlight a couple folks here. Lucia and Israel Fite, my grandparents, whose building I actually stayed in last night, and who are in their mid-90s, who are really poster children, so to speak, or poster grandparents, maybe more appropriately, for the types of programs that are being discussed in so many different flavors here. You can get a sense of, for better or worse, my family's health history reads kind of like Grey's Anatomy. So just in the last couple years, we're dealing with lots of conditions that really could benefit from somebody checking up on them pretty frequently and making sure that everything is copacetic. At the same time, some of you may have had the pleasure of knowing Bruce Graham, my friend, colleague, mentor. He and I worked alongside one another for about 3 years, and a number of months ago he passed away from Lou Gehrig's disease. Bruce was passionate about the potential of community paramedicine. He bled blue in every shade, but he definitely saw the future of this industry in community paramedicine and mentioned in the last few months and weeks of his life how much he could have benefited from being in one of these programs. I apologize if I sound a bit emotional. I certainly am. But the idea that he could have benefited from that and how we expand the viability of these programs, emphasize their necessity, goes beyond the social, goes beyond the heart of our programs, really to making sure that they can live on their own. So that said, let's jump into the hard question. Let's assume that some of you are optimistic, patriotic, possibly foolhardy enough to run for office someday, and someone comes over to you and asks a hard question like, what is the actual financial or economic, since we're talking about words and finance and economics are not quite the same, but they ask the question, what is the financial value of a fire or EMS service? Well, some of you may have faced this question. In my community, we certainly have. And there's lots of different ways that we can dig into answering this question. Lives saved, property saved. I live out in California, so what's going on certainly in Northern California is in my backyard. the value of property and lives saved is certainly relevant. I have a 2-year-old, so the Halloween costumes are not to be neglected. But the fact is there are many different ways to slice this. However, we also have both the wherewithal and in many cases the information to ask some pretty hard questions that we can dig into. Like, what is the economic value of these programs? Are the lives saved over their time worth the cost of saving them, economically speaking? Not socially, that's a whole different conversation. But in terms of what the people and the property that you save give back to their communities, can we answer that question? And the answer is almost resoundingly yes. There are some interesting discussions starting to happen now around things like crime. And does having more public safety make crime better or worse? Certainly beyond the scope of the conversation here, but relevant in terms of building out an economic model. And what I would put to you is, can we do the same thing with community paramedicine? Can we ask ourselves the hard self-referential question, is the value of the care being provided greater than the cost of providing it? And a lot of what the conversations that I've been hearing over the last couple days suggests is this is hard to answer. And in some cases, it's been answered positively. In some cases, it's been answered negatively. But in either case, we should be able to answer this question based on, again, my bias is towards data, given what I do all day. But there's a lot of discussion. It's really pretty exciting to someone in that business to hear a lot of people say, we need information. It's not just based on, again, what our heart says. And the reason for that is because these questions are complicated. Matt Zavadsky, who I'm sure many of you know or follow his work, Dan Swayze, who presented yesterday, and certainly many others, including everyone in this room who's gotten up here and presented, has really dug deeply into the questions of the system costs, saving costs and sustainability and so on. But as we increasingly look for financial stability, as we increasingly look to others to pay for these programs, it does beg the question of what do the data show? Because again, in our heart's heart, we have a sense that, of course, we're saving lives. I mean, all the compelling images that we saw on the screen of people who've been saved, the one certainly moving yesterday of the child who was stuck behind an air conditioner, right, and got pulled out because someone went and checked on their house. I mean, that's a remarkable anecdote, and there's another one I'll reference in a few minutes, from Alameda County in California. But nevertheless, we should also ask ourselves, lest we are heart-driven, like one might be to run for politics, from a head perspective, from a data perspective, what do we actually see? It starts with a hypothesis, and I think this is probably something we can call universal in this room, which would be that somebody who smokes less, drinks less, does fewer drugs, and generally does less harm to themselves over time, imposes less of a burden on the healthcare system. Show of hands, anyone who would agree with that statement? Okay, so pretty much I'm seeing nods and heads around the room. The question is, what do the data show? And it turns out the story, as you would expect, is a bit more complicated than that. I started digging into the literature to try to answer this question. And some of these statistics are still emerging, right? So many of the programs in this room are still producing the data that they're going to use to answer this question. But when you dig into the historical data, you find that, in fact, the answer is less intuitive than one might think. In fact, the costs when you look at one slice of harmful habits, as it were, one of the buzzwords that, I hope become a term of industry art that we got from the city of Dallas Fire Rescue Mobile Community Health Program. You'll see a bit more about that in a few minutes. The concept of harmful habits goes across a number of dimensions, one of which is tobacco intake, particularly when we start to look at patients with COPD and other chronic contributing risks. And among patients who stop smoking, who do what one would think is better for their health, often with the assistance of someone coming and visiting them and making sure that they haven't snuck a pack somewhere under their pillow, the costs go up. It actually makes a lot of sense when you think about the economics, because these folks are being encouraged to do better for their health. So in many cases, they may have been neglecting their health for years, which is how they got into this mess in the first place. And in the 30, 60, 90, 365 days after they quit smoking, their health care costs spike because these folks are now going to the doctor, right? They're being treated more and more effectively, and in many cases they've neglected, it's the word from the literature, their health up until this point. Well, if we are looking at community paramedicine programs efficiency over a 30-day readmission period, that may be sort of going into the belly of the beast and trying to show that you're lowering cost when you're in fact causing a spike to happen. Sort of speaks for itself. So how this affects what we pitch to our payers and to our communities and to our patients is really of the essence. And so the question is, have we and are we being honest with ourselves as a community, and do we have the information to justify the claims that we're making? Another one of those slices of harmful habits is alcohol intake. Right? Again, it's a good thing from a clinical perspective. It's a good thing from a social and patient care perspective to get people to stop drinking. But when you do that and you succeed at getting them to put down the bottle, get back on the wagon, and you effectively double the healthcare cost of that person, that may be a necessary evil from a clinical perspective, but it doesn't achieve the objective that you've sold. And so again, back to finance and economics and really the essence of business, right? You're selling a product and a program to someone who you want to pay for it. They come in with this idea that you're going to lower costs, and all of a sudden you just crushed them with twice as much cost per person that you got to not be an alcoholic. And yeah, their liver is less cirrhotic, but it's also more expensive to take care of them. Another one of these dimensions, and this one comes from a number of the programs around, but it does lead to my favorite anecdote, which I want to make sure I touch on, is access to food, transportation, really the basics of life. We heard a number of people talk in the last couple days about folks using canned soup, for example, as their three squares a day, and all the downsides that come of that. Well, I want to make sure, going back to that exploded head from a couple slides ago, that we don't suggest all of this is negative. Right? In fact, some of the data, like the data cost reduction shown by giving people access to food, is very real and very compelling. The idea that there is a cost burden on the system placed by not giving you proper nutrition. As an example, and that comes across multiple dimensions. In Alameda County, California, just south of where I am, and one of the programs I'm honored to work with, my favorite anecdote comes from that. It was about a woman who was calling 911 several times a week, sometimes 6 or 7 times a week. And there are a couple users in the county that call up to 300 times a year. So it's certainly a compelling case for the cost they build onto the system. And when the community paramedics visited her home, they found that she was malnourished, but she was eligible for food stamps. And she was calling because she didn't feel well, because she was malnourished, but she was eligible for food stamps. Why wasn't she getting them? Well, it turns out that in California, you need an ID to get food stamps. And she couldn't drive, so she couldn't get to the DMV. So she couldn't get her ID, so she couldn't get her food stamps. Sorry, I just got to chill. I adore that story, and I think it's just the most compelling story. Think about the cost burden that she was, not only to herself, to her family, to her community, to the EMS system, but they took her to get the ID. She got the food stamp. She ended up calling once in the following year. And it's for something completely unrelated to her nutrition. And all someone needed to do was ask the hard question, compelling case for this program. And then this is a big one, and it's one that I hope everyone, if you take nothing back from this presentation, from a social perspective, I hope we all start to ask the question of things like loneliness and what this sort of unmentionable, undiscussed dimension really bears on our system. Because the financial impact of loneliness is real. I just mentioned the mega users. In my own county, we've had some folks, in Contra Costa County, we've had some folks calling 911 for service up to 8 times a week, sometimes as soon as the crews leave their home. And it's not because they're sick per se, it's because they're scared. Again, I don't think I have to tell any of you this, you've all seen this and worse. But the idea that that is really something worth talking about in our communities, for sure. But I couldn't find a lot of data on this in this country. So I went back, I had to look to the BBC in Britain that found that the magnificent return on investment of $3 of system savings for every dollar spent on making sure someone has a friend. You're not even talking about care. You're talking about discussing, how was your day? And the idea that they know that there's somebody here, they're not going to die alone. Again, I think about my friend Bruce and how important it was to have people visiting him in the last weeks of his life. So I think the role for community paramedicine is clear. That's really not going to be a question for anybody. But we're talking about the numbers. We're talking about the words. So we have to ask ourselves, does community paramedicine equate to lower cost? Similarly, there's been a discussion about the data that needs to be used to capture and how difficult so many people in this room have found it to justify the cost with information. They've been told they need a separate system. They've been told it doesn't tie into their electronic health records. They've been told that this is going to, there are all sorts of investments that have to be made to be able to pull out the data and justify. It's a myth. It's simply what it is. So the first question that I always have for people when they talk about the value of electronic health records, I'm clearly going to make a little bit of a transition here, is if electronic health records are so great and everybody wants to talk about connecting with them or using them or whatever, why is it that clinicians are so angry with them? And that's a kind way of putting their experience. Show of hands in the room, how many of you have actually dug into Epic, Cerner, Meditech, McKesson, et cetera? And how would you rate them on a scale of 1 to 10 in terms of, I'm seeing a shaking head in the back, so I'm going to take that as a general sentiment. They don't generally get a lot of positive reviews in the user experience category. Nevertheless, there's this sort of propagated myth that we have to utilize hospital-side capable electronic health records to capture data in an out-of-hospital environment. I hesitate to call pre-hospital because more and more people are asking, aren't you talking about post-hospital? And now I'm starting to explain that post-hospital becomes pre-hospital, becomes post-hospital, becomes pre-hospital in so much of our experience, which is, of course, what community paramedicine really is all about. But this conversation about needing to redesign the box, the propagation of this myth is both expensive and complicated, when at the end of the day, to a large extent, I would argue that the box itself isn't really being used to the fullest extent that it can. So I'm going to evangelize a little bit for NEMSIS version 3. Some of you may have heard about this. That's coming in a couple slides, so gird yourselves. But the idea that there's really a ton of capability here that isn't being utilized is something worth thinking about. What on earth am I talking about? That's what this little picture is meant to convey. What on earth am I talking about? This idea that you could utilize the existing systems that you have as the basis for analyzing your programs when so much of what we hear is my EPCR system is insufficient. It didn't ask the questions. It didn't analyze the data in the proper way. And I would say, well, kind of. But what if we squeeze a little more blood out of those EPCR systems? What if we add something to it, sort of throw a jetpack on its back? Some of the data that you need that are captured in the EPCR certainly aren't immediately relevant to what you're doing in an in a non-acute setting, shall we say, in a non-clinical, making sure that this person has a friend type of setting. EPCR is not really great for that. But that's not to say that it couldn't be, which I'll show you. And secondarily, a show of hands if you've ever done a wellness check or community paramedicine visit and found that there was the need for an emergent call. So there are some hands in the room. This idea of scaling up a call is real. And the idea that you have multiple data systems now working in a single environment that may or may not be compatible or may or may not have been made compatible adds some layers of complexity. The one case that I think of that I went on a visit to was a case where a COPD patient who is normally sort of sitting at home, not doing a whole heck of a lot, having trouble breathing. Turns out that person got up too fast earlier that day, had a hypoxic episode, fell over, hit their head on the end of a table, and ended up with head trauma on the floor. That's not a wellness visit anymore, and a separate call ended up being made by a community paramedic to a 911 service that they were a part of to come out and do the documentation on that call. This idea that you need separate systems means you can end up with orphan data, because that information about that patient, the fact that they had an emergent call on a community paramedic call, now need to be reconciled later. That's its own set of challenges. So let's try to potentially poke a hole in that myth a little bit. So when one asks the question of what are the types of data that would need to be added, for example, to an EPCR to make it useful in a community paramedicine environment, we found that they fall into a couple major buckets. And this leads to a conversation that's a bit longer than we have time for here, but I want to get you thinking about it. They fall into a couple buckets named here: family history, past visits, mental health, and the social factors. Social factors sort of fall into the other buckets. These three primary categories have technical relevance. They are not just a good idea. In fact, those three primary categories, when added to a NEMSIS version 3 EPCR, I'm saying this on video, I'm saying this on record, I will send you all the technical slides on how to make this happen if you want them. I'll find me afterwards. When you add those 3 primary buckets of information onto a NEMSIS v3 record, you get something called a clinical document architecture output. Specifically, there are a variety of them that I can go into later, but the continuity of care document, the consolidated clinical document architecture, the CDA reversion 2, which is on the NEMSIS website. What the CDA is the subset of data that coexist between electronic health records and EPCRs. And they are the information that electronic health record systems use to communicate among one another. So when Epic wants to send data to Cerner, which sends to McKesson, which sends to Athena Health, which sends to a pharmacy, which sends to an outpatient dialysis clinic, and so on and so forth, they use CDA structured documents. This is a federal standard. Your tax is paid for this. It's organized under the Office of the National Coordinator of Health IT. And the guidelines are published on how to take that data and transfer them between those systems. When you add those 3 primary buckets of information onto a NEMSIS v3 document, you get a CDA. And that means that your information can be sent into Epic, Cerner, Meditech, McKesson, Athena Health, eClinicalWorks, and so on and so forth. And they've been like that for years. This is meaningful use stage 2 is about 3 or 4 years old already. And this was all for meaningful use stage 1. It goes back to the time of Hurricane Katrina. So this information has been around for a very long time. We just haven't really talked about it. You guys get it as an EMS and fire services in the form of NEMSIS 3. And not a lot of people have explained the purpose of NEMSIS 3. But its purpose is to rigidize, to coin a term, make rigid? Rigidize the data that you are sharing or that you are capturing and make ready to share between the systems. So on your right, you can see the time. It's hard to see some of the nuance on here, but on the right is data coming out of the NEMSIS 3 dashboard just for motor vehicle crashes. On the left is the NEMSIS 2 data. And if you look closely, and by the way, this is all on the NEMSIS website, so you can go in and dig into it on your own. The shades of detail in the NEMSIS v3 data are so much greater, but their structures are so much stricter that they give you the information you're going to need to find corollary data elements on the hospital side. People ask about this magic HL7 thing. HL7 is just NEMSIS for electronic health records. The CDA is the Rosetta Stone that goes between them. And any system that you use for NEMSIS 3 can expand itself to include that. That's important because it answers so much of the question here of people using Epic in the field. That's not quite a perfect fit. People using their EPCR in the field, not quite a perfect fit. But if you could expand one so that it translates into the other, wouldn't that be fabulous? And you'd have the rigidity that allows you to analyze that data in a way that answers both your 911 and standard EMS fire type questions, your agency related questions, and allows you to dig deep into the individual. Imagine the ability to chart someone's heart rate over a 30, 60, 180, 365 day period to prove the value you're providing to that CHF, COPD patient's family, to chart their blood glucose levels for a diabetic patient, to see how many times they actually fell down, et cetera, in a fall risk patient. And the idea that you can share that data with other clinicians in a way that they can use now allows them to say, I see the value you're providing. I see how it matches onto my system. I'm not just seeing a PDF in my system with a run sheet that I may or may not be able to read. I can consume this data into my EHR and I can analyze it. And guess what? It can give it back to you too. So community paramedicine encounters may not be clinical, but at the end of the day, they need to be measured. This has been a running theme of the last 2 or 3 days, which makes my heart sing, to use a phrase I recently read and kind of loved. If you can't measure it, you can't manage it. Pretty famous saying, attributed to lots of different people, which I find funny. But I'm going to show you in my remaining couple minutes an example of what the Dallas Fire Rescue's mobile community healthcare program is doing in this specific case. They did hire my firm to add 1,000 data elements onto a NEMSIS version 3 record. That's a lot of data. Turns out they're not going through it all the time, but the information is there, it's available, and it's formatted such that it can be shared with over 20 hospitals in the Dallas Metroplex area by contract. So the ability to hand off this information in a consumable fashion is happening today. I want to highlight what they added to this NEMSIS 3 system. NEMSIS 3, because it's so rigid, is basically the same. In every EPCR system, you're going to see it. It's supposed to be that way. That's how information can be shared between these systems. And in fact, in Dallas, they have a different EPCR system. They're using a system from Sansio. So they brought in 2 different companies whose job it is to share information between the 911 system and the post-acute frequent users of 911 system, and make sure that our information can be shared. They added elements to this system like harmful habits, female health, and diet and exercise. The female health one, by the way, should be in NEMSIS. The fact that that's not there, I think someone needs to call NEMSIS and let them know that this information is actually pretty rich. It's a lot of women in this world. It's kind of important that we be able to track what their experiences are, but it's not there. So they added these data elements, and they are remarkable, if only for the fact that particularly harmful habits are among the only pieces of data that we as an industry capture that can be directly mapped onto financial value, actuarial value, which is essentially risk. Right? If you can take somebody over a 30, 60, 180 day, 365 day period from 6 packs a day to 2 packs a day, as we saw earlier, you may increase their costs on the healthcare system now. But the rest of that quote showed that their costs go down over time once their health sort of levels out. What you also do is reduce their long-term risk on the system. So the idea that you can lower their actuarial risk, the long-term insurance risk, is I was very excited to hear the mention yesterday about Anthem Blue Cross getting into this business, and the folks from Massachusetts, and a payer, right, getting into the idea of I want to support community paramedicine efforts. Those are the metrics that payers use. Are you lowering my short-term risk, but more importantly, my long-term payout risk for this person's health? And I have to be able to track that information so I can prove it. Alcohol is another example. So questions that are asked of the patients about have you ever been asked to cut down on your drinking? There's another set of questions I'm not showing here, but it's remarkable. Like, do you have a primary care physician? Yes or no. Do you know what a primary physician does? Yes or no. I mean, it's remarkable to have those 2 questions next to each other, but they tell you pretty important and different things. Another set of data, caffeine intake. Are you drinking coffee instead of eating properly? Are you drinking coffee as a way of having a diet and then finding that you have stomach ulcers? The idea that you can take these data and map them onto clinical value is real, but if you're not capturing it in the first place, how are you making those correlations in anywhere where you can prove them on a screen that I've reduced your caffeine intake and I've increased your nutrition and so on and so forth, and you're not coming back to the ED as much? Well, maybe there's some value to that program. Another one that's been really interesting to add into the system is something called a PEAT score. I'm a show of hands, how many of you have heard of a PEAT score? Not a whole lot, and I think that's important. Right? So the PEAT score essentially is another measurable analytic value that looks at things like the cleanliness of your house. Do you live alone, or do you have someone with you, and under what conditions do you live? Is your home a hazard? So are there things that often I've been inspired by hearing community paramedics talk about going into the home and rolling up the rug, right? I mean, such a small criteria, but at the end of the day, when you go to your care facility or to your payer and essentially say, pay me for this work that I'm doing because I reduced the number of times that this fall risk patient showed up in your ED over the last 30, 60, 180, 365 days, and I can't show something like I rolled up a rug. Well, what's the cost? What's the value of rolling up a rug? I mean, not a lot, but it's better than zero, right? My time is money, and folks are going out in the home and providing a service. And so you got to be able to document that so that you can say, this is what I did. This was a condition before I got there. 3 weeks later, that rug is still rolled up. So now that hazard number is lower than it was before, and there's value there, and I did that. And if you can prove that, then you can justify your cost. And the last bit is your ability to analyze it. And I know there's a lot on this screen I wanted to show. But again, there's been so much talk about the ability to, or non-ability to slice and dice this data the way you want to. And so I wanted to highlight that the Dallas Fire Rescue Program had about 40 analytic measures that they knew they wanted. What was remarkable was before they brought me and my team in to help them with this, they were using something called InfoPath to do that documentation. If none of you have heard of InfoPath, you have had a better life. Take Microsoft Access and make it worse. And you end up with InfoPath. And it turns out they were capturing a ton of data and had no way to slice and dice it. But they actually were sitting on this stuff. And it was remarkable when they charged us with saying, we need you to help us analyze the data. And it turns out they had it all there. They knew what they wanted to look at. They just didn't have a way to do it. So we had them, I did with the medical director of the department and with the EMS chief, we did a design session. It's about 2 or 3 hours with a whiteboard, basically saying, no one's ever asked me to land an ambulance on the moon. Actually, the medical director then replied, I don't care if you can land it on the moon, I want to know that you can bring it back. Of course. Way to move that bar. But the point was, when I asked these folks, there's not a lot of folks who run a bigger program than Dallas Fire Rescue, and they're capturing enormous amounts of information that they don't have any way to parse. And I essentially said, if you're capturing all this data and you're spending a lot of money to do it, what do you want to ask? And they didn't have an answer, aside to say that no one had ever asked them that before, which I thought was a pretty compelling case. So I suggested that they come up with some suggestions. And after about 15 minutes, the floodgates opened. And I just want to mention it here because I think it's brilliant. The medical director of the city of Dallas, Dr. Marshall Isaacs, has something that he refers to as prime numbers. And essentially, these are patients, particularly who are drug seeking, who find ways to fall off the grid. And what that means is if you're coming in through a 911 service and there's a CAD call associated with you and there's an EPCR associated with you, I know who you are when you show up at the hospital on Tuesday. Then you get discharged. Wednesday, you walk in. Thursday, you get someone to drive you to a different hospital. The following week, you're taking a bus to another facility. Your HIE doesn't see all of this because HIEs are their own complicated beast. You're not coming in through the 911 service every time. These different hospitals are not necessarily connected. And meanwhile, you're seeing 5, 6, 7 different clinicians to get your drugs and other substances that you're looking for, and the system doesn't see you. And when you come in the following Tuesday again, well, it looks like you've had your second encounter in 2 weeks, and everything else is blind. And his challenge to the systems, the tech systems in this arena, let's close that gap. And there's no reason we can't. Electronic health records and EPCRs can talk to one another. EPCRs and EPCRs can talk to one another. Community paramedicine documentation can layer onto EPCRs, so those talk to one another. HIEs are begging for systems to send them data. And if your takeaway from today is that all of this is possible, then I've done my job. It is a very exciting time to be a geek in this business. And so if I can provide any additional detail on the how these types of interoperability efforts happen, again, what your tax dollars paid for, please see me afterwards. I'll be happy to send everything by email. Thanks very much.